whole thing in the IRSI. Gaurav, all yours.
Thank you, Dr. Amar, and it's indeed a privilege to be in your course. And after those amazing videos from Dr. Amar and Dr. Suhas, from whom both I learn all the time, let me see if I can share something worthwhile. So this is one case presented to us, unilateral one-eyed patient, because fellow eye was lost to multiple VR surgeries. And this eye, he waited from being 618 for almost 10 years till he was like finger counting 3 meters, and finally there was no choice but to get operated. This was also a vitrectomized eye following a VR surgery, and had a phacodonesis and significant, very hard cataract. So we had to plan a surgery keeping all these things in mind. And also had significant astigmatism, so we thought that if we'll get a chance, we'll put in a toric lens, but that was not the most important part. So you can see that there is enough phacodonesis as we make the rhexis, and although we would have liked to make a bigger rhexis, we ended up getting a 4 millimeter rhexis, and with such a hard cataract, it was probably not adequate, but then we decided to go ahead. You can sometimes manage with a smaller rhexis as well. Put in capsular hooks to support the bag, and started off. There were 3 capsular hooks. They were looking like they were enough, and you can see that it's a very hard cataract. Patient had VR surgeries and oil removal, so the capsule was expected to be friable, and as you can see that the bag was very mobile, and it was moving all over the place as we went through with this. But at the end of the cataract removal, we realized that the capsule was totally stuck with plaques, and there was of course this big central plaque, and then there was cortex which was very densely adherent, and of course it was a very friable capsule, highly amenable to zonular dehiscence. And as we tried to peel off all the stuff which was stuck to it, we managed in almost 5 minutes, we managed to remove only a very small part. And here I know that Dr. Amar would have said that why are you wasting time over this, and just get it out and do a scleral fixation. But this patient had 2 prior retina surgeries, and had detachment which had been sutured. We would have wanted to preserve the bag if possible. So after wasting a lot of time, I managed to clear only that small area which was less than 91 quadrant. So I went in with this other way, which is something that I've kind of been doing for some time, and you can see what I'm doing here. I'll go from the main port with only the infusion. I've just taken it back a little bit just to show you. So I go in from the main port, which is leaky. So it's a infusion cannula which I'm now pushing in through the main port, and keeping the posterior lip depressed, I've set up a high flow system where I'm kind of doing a jet wash or a jet polish of all the stuck plaques and cortex and the equator of the bag where there is resistant cortex. So this works very well because you are not trying to aspirate, you are not trying to pull, you are just setting up a passive flow, and that too you cannot do it from the side port because you won't set up a flow. You have to do it from the main port, and now I'm doing it from the side port but keeping the main port open. So again I have a lot of flow, so I've gone to the other side, and all 360 degrees I've managed to loosen up everything, and now in few seconds I'm able to remove all that thing which was stuck so nicely. But now it becomes very easy to get out because it's all been loosened up. So this is what I use as the jet polish or the jet wash. And now we have to of course deal with this central plaque, which will require it to be peeled, because the only other option would have been to do it with a cutter or maybe make a small rhexis in the center. So we gently peel it. Again, as you understand, the capsule is very, very friable, so you have to be very careful, change hands, change directions, pull it in one direction, then the other direction, so that you don't rupture the posterior capsule, and very gently nudge it and pull it, so that if you can somehow get it off. Most often you can, and sometimes you end up burning your fingers as well. So we keep trying, and you have to keep refilling a little bit of viscoelastic, but don't overfill, because if you overfill then it goes way behind, and then if you underfill then it makes the capsule lax. So you have to just keep it right. And then doing this, you can see the folds on the capsule and the stress lines on the posterior capsule, and I was keeping my fingers crossed. And like, this is a nicely edited video, so the duration is much shorter than what it might have actually taken, as you can understand, but we managed to get it off, and it was a big feeling of success. And I thought that now my job is over, but as Dr. Amar says, it's not over till it's over. So I was going to put in my toric lens. I'm sorry, there's some editing error there. And now I'll just hold it here. Now I was just getting ready to just remove some of that little bit of cortex and then put in my lens and maybe a CTR to stabilize the bag, and that would have been it. So I went there, and the mistake is that I'm going too far. My rhexis is small, and my bimanual handpiece, instead of using this hand to go there and aspirate, I've gone from this side and I break the rhexis. So all that hard work goes to waste because this patient was planned for a toric IOL. All the same, we aborted the plan to put in a toric IOL here because it was not the most important thing. We had been able to do almost everything else except I would have loved to put in a CTR, and at this point the thought did creep on my mind that I can just sacrifice the bag and go with some other form of fixation of the lens. But I decided here because I felt that the capsular bag was stable enough not to dislocate very easily, and patient was already about 80 years old, and I didn't want to prolong the surgery. So in the end it ended well, but you can work very hard, and then towards the end, if you just become a little complacent, and you can have these situations. This is the Trypan's blue test which I do to check for any leaks at the end of surgery sometimes, and it works very well to identify those small, just like a Seedles. So going on, this young lady was bilateral ICL done by us about 5-6 years back. During COVID times, she managed to come back with the recurrent episodes of acute uveitis with even hypopion at one time. We would treat her and send her to the rheumatologist, and she was investigated and put on treatment. She would fall out of treatment and then come back again after 3 months or 6 months. So 3 episodes, and then finally she developed a cataract in both eyes. One of them was as intumescent as this. We did a YAG because there was a big this was a YAG iridotomy done because she was developing an iris Bombay at one point. That was resolved and the glaucoma got controlled, but finally we had to go with the cataract. So as we went ahead with the cataract surgery, we had to first obviously remove the ICL and then stain the capsule, and I find it difficult sometimes to have viscoelastic in the eye, and this obviously this lady also had high astigmatism. She had a toric ICL, so we wanted to correct with a toric lens if possible. So I decided to first explant the lens without using viscoelastic under infusion. I like to do a lot of these procedures under infusion itself, like capsular access sometimes, and of course all my lens implantations are done. Even ICL implantations I usually do under hydro implantation as well. So I'm quite used to these maneuvers. So under infusion itself, I managed to get this ICL out of the sulcus, and it required a little bit of manipulation. The pupil was very tight because post uveitic it had become a little rigid and would not dilate beyond that point. So doing bimanual maneuvers, was able to kind of get the one foot plate out first and then the other one, and then of course it becomes much easier. And once the ICL was out of the sulcus, we stained under the ICL so that the capsule could be stained, and then we could obviously put viscoelastic and explant the ICL. So this is the ICL coming out, and things look good. At this point I go back and inject some Trypan blue and stain the capsule so that I can do a good capsulotomy later on, and then of course we explant the ICL. Okay, I'm sorry, I think I gave it away for a moment. That's the stain, and then the ICL comes out, which is again not very tough. Now it was a very intumescent cataract, so I had decided to kind of aspirate the cortex a little bit because I was worried about the integrity of the rhexis. So I went in to decompress the lens, and as I thought that I'll just decompress, putting in a lot of viscoelastic, and I touched it to puncture it, and it just went into a flag sign. So it was very, very intumescent. So now I was in a situation because I didn't want anything like this to have happened, yet we had to manage it. So we went ahead, managed it. Again, toric lens was aborted, I think, and we managed to put in a we did go in with the toric lens because it was in the axis where it didn't matter. So finally now we had to go with the second eye, and here we decided that because that was also becoming intumescent and the ICL, there was almost no vault left post uveitis. So we decided to go in with the femto assisted surgery, and we planned a surgery where the ICL was going to be, the capsulotomy would be done before, so that there was no risk of a flag sign. So this becomes a really useful modality when you're dealing with such very intumescent cataracts, especially if they are also linked with a associated with a situation like this. So the problem is that the laser does not recognize the benchmarks, and it mistakes the ICL for the anterior capsule. So when the scans happen, you have to set them right. Sometimes it even misses the cornea. You can see that the cornea is also looking off, and I have to reset the corneal landmarks, and it goes totally haywire. And so, there was one patient where it actually picked up the limbus as the pupil and the ICL margin as the as the limbus. So the limbus was smaller than the size of the pupil. So I was kind of totally, confused what the laser was doing. But we can't blame it because it's not meant for all these things. So finally you can set the landmarks yourself, but you have to be careful that you set the posterior capsule and the anterior capsule, and then of course the capsulotomy becomes much easier as you fire this. And to cut the story short, we were able to do this well, and then the whole surgery was mostly uneventful and we could complete it. So this is a useful modality when you're in a situation. Now coming on, I think this is another patient where one of Dr. Amar's innovations comes in use. This gentleman came to us with a very nicely done multifocal IOL in one eye, and the second eye his surgeon refused to do it. He said that I'm not interested in doing the second eye, so you can go get it done somewhere else. So he landed up with us. This eye had poor vision since childhood and had a pupil which was mostly peaked towards one side, and we had to go ahead and operate him, and had to put a multifocal because he had a good multifocal, and there was good visual potential in this eye because his previous records showed that he had fairly good vision in this eye, in spite of the fact that he thought he did not. So once the pupil was dilated, it looked much better. We decided to put a toric multifocal for him, but then we had to do something about the pupil as well. So as we started doing the rexus and I had taken almost a full round, I realized that in the same area where there was iris abnormalities and there was a problem, this pupil, the rexus started running out. So you will see that it has already run out till here, and in spite of my best efforts using the Brian Little's maneuver and every possible maneuver, it would just not want to come back. The capsule was also fibrous under this area of the iris for whatever reason. And you can see that now I have a flap which has almost reached the pupil edge. I go from the opposite side thinking that I might be able to do a better job, but it only makes it worse. And now I have to resort to, it's almost going to run out completely now. So I resort to a Y-tipped manipulator, go and expose, and go with my second microrexus forceps, go under that, I do get some exposure. And with the fourth Brian Little's maneuver, I was able to, usually it works just one time, I was finally able to retrieve it from the edge, like right from the edge, bringing it back from the edge, and finally I was able to complete it. So once I did that, I was again kind of relieved, thinking that now I can go ahead, and went ahead and removed all the cataract, and everything was clear. And when I decided to put in the lens, put in viscoelastic, again I thought we have a runaway rexus because I couldn't see the edge of the rexus. So I thought, now again I've done it. And then I had to, to reassure, I had to go back, use the Y-tip manipulator in that area and check that what I had done. But thankfully, right in the periphery, I could see that the rexus was complete. Went ahead and injected the toric multifocal, centered it, and did a centration check, and then went and did a sphincterotomy in the exact opposite axis to where the pupil was drawn, because now I had to centralize the pupil. So I'm going to use Dr. Amar's technique of the single pass fourth throw, which has become one of my most favorite techniques. It's a rescue thing which works every time. Put in pilocarpine, constrict the pupil, and then do this. I call this as the railroading technique. I learned this the hard way. You can hold it with a forceps, or you can just use this. I use the 26 gauge, go exactly where I want to pass the suture, and then pass the suture from both sides. It works very well for me because it gets you the exact bite of the iris, and you can make a perfect single pass fourth throw and come out, and then you can obviously suture it. So in the end, we did well with this patient and finally managed to center it. Looked really good. Patient was very happy. We gained 6/9 vision, almost fully corrected astigmatism post-op, and did quite well like this. I think I'll just, because there was discussion on the iris segment, I'll just show a quick one which will take maybe a minute or two. This was a patient was treated by us for trauma with the iris loss and perforation repair, and eventually developed a cataract, and over 3 to 6 months we realized that we'll have to do something. So there was a big defect, and we thought this was not amenable to a single pass fourth throw, so we had to plan something. So we got a segment designed, and there was also astigmatism, so we were going to use a toric lens, and this is finally the design that it's an Indian design, but it seems to work well. The only problem is, as sir said, we'll have to implant, it's very big, we'll have to implant it in the sulcus, you can't go into the bag. So went ahead with the surgery. Surgery was fairly good till we reached the point of, getting this out, and got the rexus there, and injected the lens and put in a toric lens. And now we have to implant this. Now initially it was very tough because we didn't know which way to go, and then initially we thought we might try to get it in the bag, but there was no way it would go inside the bag. So finally we found the right way of doing it, and this was on the 4th or 5th attempt. I had to enlarge the incision a little bit. It wouldn't go in from the 2.2 that I was using, almost a 3.2 now, and finally we positioned it in the sulcus. It came out really well cosmetically as well as functionally, and eventually this patient looked good in the end, and we had a great outcome. And also refractive result was excellent, and patient went on to have a good toric alignment, and eye trace showed that we had got it perfectly right. There was almost negligible astigmatism left, and went on to develop 6/9 good vision with good cosmesis and good functional vision. So we don't know how long this pigment will last. You know, they're doing a good job. I have my oldest aniridia rings are now 15, 16 years old, and they're holding on. We haven't had much pigment loss yet. So,
thank you very much, Gaurav. Ladies and gentlemen, I want to thank each one of you. We have come to the end of the session. If you have any doubts, we are all outside. We can answer them for you. I want to thank all of you for coming for this final session of today's day. And tomorrow there is the Ophthalmic Premier League. Please check the timing. It's in Hall A, and I hope you'll enjoy that. Okay? It's at 2:30 tomorrow in Hall A.